We do have our next speaker with us. Dr. Mark Ghalili is here, all the way from Beverly Hills, California. Dr. Ghalili is, besides being a great friend, has become a doctor to a lot of famous people and celebrities in Beverly Hills, which is going to unfortunately take him away from us this weekend, so we won't have him around for the whole time, but we're lucky to have him here today. And Dr. Ghalili, come on up.
Nice to meet you all. I'm Dr. Ghalili, Mark Ghalili from Los Angeles, and I wanted to talk about peripheral neuropathy because I'm sure all of you guys have patients with peripheral neuropathy. You always complain of symptoms. There's millions of people on gabapentin for no reason. So I thought I'd actually explain. I've done a lot of research on this and treated a lot of patients with it. So I thought I would explain how peripheral neuropathy actually works and what we can do to address it and fix it from a regenerative medicine standpoint. So what is peripheral neuropathy? There's 8 million cases in the US, multifactorial causes. We know it can be caused by vascular disease. That's like narrowing of the vasa nervorum, which provides blood supply to the nerves. There's endothelial dysfunction, and that's from cardiovascular disease, restricting the amount of blood flow to the extremities. And the third is the breakdown of myoinositol. That covers the myelin sheath, thus reducing ATP activity when that gets broken down. So I'll show you a slide. There's a photo. So if you see you have your healthy nerves and blood vessels, you see that unmyelinated and myelinated nerve fibers. They look pretty healthy. They're sending proper signals. But when you get the nerves and blood vessels damaged on the right, that's when you have an occluded vasa nervorum, not providing enough blood flow to these small peripheral nerves, and then you get damaged myelinated nerve fibers. So again, endothelial dysfunction is also important. That can happen with diabetes, high homocysteine levels, which can be found in patients with MTHFR gene mutations, hyperlipidemia, leading to endothelial dysfunction, atherosclerosis, or high blood pressure, even clots, which then you don't have enough blood supply to the nerves, and you can get neuropathy. So this is what I wanted to discuss, is that breakdown of myoinositol. The myelin sheath breaks down, and then you end up with a nerve fiber that cannot send a proper signal. So the cell body can't send a proper signal to the axon, leading to misfiring. This can lead to symptoms like burning pain, fasciculations, and even hyperreactive deep tendon reflexes, which we're going to show later in the presentation. So what are the types of neuropathy? Okay, we know it can happen from diabetes. That affects the small fibers. And the majority of patients have, what I'm going to discuss is that small peripheral fiber neuropathy. There's also peripheral, which is small, medium, and large fibers being affected. There's medication-induced, which I want all of you guys to start asking patients if they've consumed medications we're going to talk about that can be the root cause of their neuropathy. Alcoholic neuropathy, we know that can happen due to the thiamine deficiency from them not absorbing vitamins properly. And then I like this diagnosis, fibromyalgia. I personally don't believe in fibromyalgia. I don't think it's a real diagnosis. I've seen many patients that have been diagnosed with fibromyalgia, and there's always a root cause. So you can always find a reason why, usually by big pharma drugs, which I'm going to discuss later in the slides. So features of small peripheral fiber neuropathy. It's kind of like stepping on a Lego for patients. And I've experienced it myself, and it's absolutely horrible when you take those first steps in the morning and you have these pins and needles and buzzing in your feet, and the patients, really don't like this. You get this neuropathic pain, you get a stocking glove pattern of pain in the hands and the feet, and dysautonomia. So dysautonomia, that's like dysmotility, or they can say, I don't swallow my food properly. Even palpitations. So some patients have palpitations, and that could be a sign of neuropathy, not sending proper signals to the Purkinje fibers in the heart, leading to palpitations. Sexual dysfunction and even sweating can occur. So here's a slide of what small peripheral fiber neuropathy actually looks like. You have a skin punch biopsy. This is the gold standard of diagnosis, by the way. If you look at the left, you have normal epidermal innervation of the nerves, right? You see those strings coming along, that's a nerve supply. If you look on the right, you have small fiber neuropathy. You have denervation in that epidermal layer. So we know that epidermis plays a significant role for the small peripheral fiber neuropathy. Small things you can ask a patient. Hey, are you shaving, you ask a woman, are you shaving your legs in less frequent intervals? Because the hair won't grow as fast. Look at their skin. Do they have smooth, shiny, dry skin on exam? You can kind of push your hands through their legs and see if their skin is kind of crinkling. And that's a sign of peripheral neuropathy as well. So any patient you have with neuropathy, please ask them these questions. Have you ever consumed any of these drugs that can cause neuropathy, such as fluoroquinolones, Cipro, Levaquin, Avalox, at any point in their life, Flagyl, which is metronidazole, Macrobid, which is used for UTIs and many women, INH, we know causes neuropathy, Dilantin, any chemotherapy drugs, amiodarone, and any medication that has fluoride in it. And I'm going to explain how fluoride can cause neuropathy if taken orally, based on studies. So these are some more drugs that can cause neuropathy, or even worse than neuropathy if you do have it. Advair, all the statins, because they're fluoridated. Celebrex, again, fluoridated. Decadron. So you have some patients who get COVID treatment, they come back with neuropathy. I think it's because the hospital throws Decadron at them in high doses, suppresses their immune system as well. May have a short-term benefit, but long-term, these drugs do have side effects. Diflucan for yeast infections, which is fluconazole, Flonase, Flovent, Haldol. There's actually one, canagliflozin, which is a blood sugar medicine. You think, why do they put fluoride in a blood sugar medicine? Doesn't make any sense to me. And I had a few patients with HIV who continued to have neuropathy, and then I went to look up the drugs. I said, well, let me go look up all these emtricitabine, and there's like all the Norvirs, all these different types of drugs for HIV. And I realized the majority of them have heavy fluoride component in the medication. So I just don't think that's going to help them with their neuropathy. And also SSRIs, Paxil, Prozac, Lexapro, Celexa, these are all fluoridated to enter the central nervous system. Very important to ask. And I promise you, if you guys ask them these questions, you might be able to figure out why they're having neuropathy and why their symptoms aren't getting better or improving. So this is a study done in Neurologia magazine, the effects of fluoride on the central nervous system. So this is explaining that fluoride can accumulate in the body, and it's been shown that continuous exposure can have damaging effects on body tissues, particularly the nervous system, without any previous physical malformations. I'm going to talk about how medication-induced neuropathy works. So this is a great study, and everything's going to explain why neuropathy happens from a completely different standpoint. So paclitaxel is a chemotherapy drug, and paclitaxel is a study about how it induces peripheral neuropathy and caused by the epidermal reactive oxygen species and mitochondrial damage through conserved. It's an enzyme called MMP13. This plays a significant role that I want to discuss with everybody. Matrix Metaloproteinase 13. So this enzyme activation leads to the oxidative stress, which I'm going to explain how it causes neuropathy. So, matrix metalloproteinase 13 enzyme, this degrades collagen. And I'm going to explain how degradation of collagen will then play a role in worsening neuropathy. So you have a normal cell, and then you get free radical damage from the MMP13 enzyme, which can lead to severe oxidative stress and cell apoptosis or necrosis. So the MMP13 is increased by drugs like paclitaxel per this study. So this increase in MMP13 triggers oxidative stress and peripheral neuropathy in the nerves of the skin. We know that it's proven through scientific studies. So I started thinking about this, and I treat a lot of patients with fluoroquinolone toxicity who've been damaged by antibiotics, by a specific class of antibiotics. And they also, black box warning, peripheral neuropathy is a severe side effect. So I thought about this, and I said, okay, well, fluoroquinolones block proline hydroxylase. Proline hydroxylase is a precursor. You need that for type 1 and type 3 collagen production. So the majority of my patients suffer from this peripheral neuropathy after taking certain antibiotics. Even Flagyl, Macrobid can do this too. So if you can't create the collagen, why is that leading to the neuropathy? So I put it together that it's also likely increasing MMP13, right, leading to this oxidative stress, apoptosis, and damage in that endoneurium, which I'll describe later. You can also get an increase in malon dialdehyde. That's an enzyme, MDA. You can measure that through a lab test. It's a marker of reactive oxygen species, and that's elevated with oxidative stress. That damages your myelin sheath, leading to axon degeneration. So this slide is very important. I'm going to discuss the intraneural connective tissue surrounding a nerve. You have your endoneurium. The endoneurium plays a significant role. It's surrounding each nerve fiber. But what's it made of? It's made of collagen and fibroblasts. So your nerves are being protected by collagen and fibroblasts. You have your perineurium, which provides the mechanical strength and the biomechanical barrier, and then your outer epineurium, which protects the fascicles and vascular supply. So let's take a look at this. These are the layers of the nerve. And if you go look at that bottom pink portion where it says endoneurium, you can see, well, that's where your nerve comes out of. That's where your Schwann cell, that's where the axons, that's where everything is. Your nerve fibers covered by that endoneurium. But we just discussed that these drugs damage collagen and fibroblasts, but the endoneurium is composed of collagen and fibroblasts. So there we go. That's our answer. You're damaging that endoneurium, and then you get neuropathy. I mean, it's pretty simple, and if you think about it logically, that's what's going on with many of these processes causing peripheral neuropathy. It all lies within that endoneurium being damaged by the increased MMP13. You get loss of type 1 and type 3 collagen fibers, and then you open up that fascicle to the Schwann cell, damaging that myelin sheath. So like how to diagnose neuropathy properly. Ask patients these questions. Well, obviously ask their symptoms, medication use, of all the medications we discussed earlier. Do you take ibuprofen or steroids? I mean, I'm a firm believer when patients continue having steroid treatment, if they already have neuropathy, it can potentially worsen their neuropathy. Ibuprofen can worsen your neuropathy. Are you on antidepressants? Are you on PPIs? Pantoprazole. Many of the PPIs are fluoridated, and they can worsen the neuropathy once patients already have it. Do you use statin medications? Obviously, we talked about fluoroquinolone antibiotics like Cipro, Avalox, Levaquin, Flagyl, Macrobid. Skin biopsy is the gold standard. And one test I like to do to diagnose peripheral neuropathy, I'll ask the patient to kind of stand on one leg with both their arms across their shoulder and to close their eyes. And if they start falling all over the place, I'm pretty confident they likely have peripheral neuropathy because the small peripheral nerves aren't sending the signal to their brain of where they are in space and time. So they kind of lose control and kind of wobble all over the place. But if you can close, that's why poorly controlled diabetics rely on their eyesight to see, and they can slip and fall at night because when their vision's not working, their nerves aren't telling them where they are. So I think that's an important test to do for patients to get a diagnosis. I have a video, and Sean, can I play this video? What do I press? Just hit it. Oh, there we go. Is there sound? Consumed 12 different rounds of antibiotics, including fluoroquinolones like Cipro, over the last 8 years, and she drove from Washington to come see us today. I want to do it before and show you her deep tendon reflexes and how her body's responding when you tap her reflex to show the damage done in the central nervous system. So take a look right when I tap her reflex. So Meg, do you notice your whole body's jerking?
Yeah.
What do you feel?
It feels like a jolt up my spine.
So we're going to do a repeat video when she's complete with treatment to see the before and after. Okay. So if you see from that video, you tap her deep tendon reflex, her head is completely jerking. She has a full jolt going through her body, and she's been living with this for a long, long time. And I'm going to show you and talk about some simple treatments you guys can do in your office as well to help these patients. So this was 6 days after a few treatments. And there we go. You're back with Meg. 1 week into treatment. Right, when did we meet?
A week ago tomorrow.
6 days, sorry. Well, I'm going to show you a reflex now. It's crazy. So you're going to see your reflex. Your head's not moving. How does this feel now?
Fine, normal.
Do you have any jolt going through your spine?
No.
How do you feel overall after the treatment we've completed?
Great. Really good.
What's improved so far?
My brain fog, my memory, my energy level, my stamina, my joints, muscles, everything.
You went to Griffith Observatory, didn't you, over the weekend?
We did. We went to Griffith Observatory and I went for a short hike. First time in 2 years.
Are you in pain?
Nope.
Wow.
Nope. It's awesome.
Amazing.
It is amazing.
I'm proud of you.
It is amazing.
So in this video, you tap the reflex again. There's no head jerk. There's no full body jolt. The neuropathy has calmed down. She's able to function. She can live normally again. And I'm going to talk about some things that you guys can do to get that to happen. I'm going to show you one more video. I have tons of these, but I picked these two. So this patient he drove from New Jersey actually, because he couldn't tolerate being on a flight, but he had severe head jerking with deep tendon reflex testing and full-blown neuropathy. And I really do think it's possible to reverse neuropathy. So I'm going to show you this video. I will show you what happens to a patient's deep tendon reflex when they are poisoned by the antibiotic Cipro. Watch. I will tap the reflex and focus on the patient's face. Full body jerk going on. This is fluoroquinolone toxicity caused by myelin sheath nerve damage to the nervous system. Edward is finished with his 5-day program. And if you recall from his video when he initially came in, I told you his nervous system was very hyperreactive. He had head jerks every time I tapped his reflex, and his brain was going haywire. Tell me how you feel right now.
I feel a lot calmer from head to toe. Like my reflexes aren't, my whole system doesn't feel as out of whack. Let's say, I feel a lot more stable, a lot of relief.
How's your neuropathy?
I haven't had any burning pain since I stopped treatment, and then slowly the achiness and uncomfortable feelings have become less and less too in the past several days.
How many days ago did you meet me?
Oh, it was Monday of last week. So I'm on 5. I'm doing the 5-day treatment plan. It hasn't even been 2 weeks.
Okay, 5 days of treatment. I will show you the reflex. Watch this, unbelievable. This is your reflex right here. Your head is not jerking. The reflex is going off. See? Look at the leg. No head jerking. But you see the reflex is still going. So.
It just, I just feel a lot less of a whole ripple effect through my body, so maybe that's why I started having a lot less pain and discomfort. Thank God for that.
I'm glad. I think your central nervous system is on the way to healing. As you can see, there's no head jerking when I'm tapping reflex anymore. You're not having that hypersensitive feel. So I think you're on the way to recovery.
Thank
and
you so much.
we got some way to go, but this is a dramatic improvement from what I'm seeing based on my exam.
I did not expect this in this short of a time period, so thank you so much, Doctor.
Pleasure, brother.
Thank you.
Pleasure. So thanks for watching that. Basically, same thing, hypersensitive reflexes with head jerking, full body, completely gone. Neuropathy is subsided. He's doing much better now. But I do want to say there is hope for this. They don't need to be on gabapentin for the rest of their lives, and that's the whole point of me showing this. So what are some key nutrients to treat neuropathy? Very important. So magnesium is very important for all these patients. You got to give them magnesium. It has an antagonistic effect on the NMDA pain receptors. Alpha-lipoic acid is significantly important as well. So we know through studies that alpha-lipoic acid, oral treatment with alpha-lipoic acid for 5 weeks improved neuropathic symptoms and deficits in 187 patients. with diabetic symmetrical polyneuropathy. So we can give that alpha lipoic acid orally, even do it through an IV. I think it works great for neuropathy. We know that neuropathy has been associated with increased production and decreased clearance of reactive oxygen species. Oxidative stress has been suggested to contribute to the defective nerve blood supply and endothelial oxidative damage. Remember, I discussed the endoneurium that covers the nerve cells. So alpha lipoic acid, proven through studies, can help offset that, but you probably don't know about it because it's not a pharmaceutical drug. And then one important thing is vitamin B6. So a lot of patients who have neuropathy take a multivitamin. Well, I don't think it's the right thing to do, because when you overtake vitamin B6, you can worsen the neuropathy. So the most common symptoms associated with B6 toxicity are actually similar to B6 deficiency. So a patient can experience sensory peripheral neuropathy, ataxia, and disequilibrium. There was one large study that found patients also could experience hyperesthesia, bone pain, muscle weakness, numbness, and fasciculations from too much B6. So just tell patients, hey, be careful with how much B6 you're taking. Shouldn't be taking a multivitamin with heavy doses of B6 every day for months and months. Maybe back off on it and take it once a week. And obviously remove all fluoridated compounds and medications which can potentially worsen their neuropathy. So any med they're on, put in the name, put in space chemical structure on Google, CBCNF. If they have neuropathy, take them off or wean them down. And I think that's going to be important. So two things I didn't mention here that I want to talk about. We know the endoneurium is composed of collagen and fibroblasts. So give your patients collagen. Throw collagen at them in high doses. Make them take a lot of collagen, because that's going to help with that endoneurium lining to prevent the damage from happening to the nerves, right? And that's what the MMP13 did. It degraded that collagen and fibroblasts in the endoneurium. Simple. And adipose stem cells. I think adipose stem cells play a huge role. Why? Because there's that M1 to M2 macrophage shift, and we know that M2 macrophages help with wound healing and tissue repair. So if we know neuropathy, based on these studies, is caused by endoneurial damage to the collagen and fibroblasts as well, we would want an M2 shift in order to help with wound healing and tissue repair.